Welcome to the UT Healthy's Texas Virtual Education Series. Today's presentation topic is abdominal pain, featuring Dr. David Young, board-certified general surgeon at UT Healthy's Texas Physicians in Tyler.
Hello, my name is David Young. I'm a board-certified general surgeon, and I've been in the practice of general surgery for over 22 years. And today we're going to be discussing abdominal pain. Now, abdominal pain is an expansive topic that you could literally spend a day talking about, but I'm going to compress the topic into approximately 15 to 20 minutes, and hopefully you'll come away with a better idea of the different types of abdominal pain, some of the various things that cause abdominal pain, the things that go into working up abdominal pain and evaluating a patient that may have these complaints. And then also at the end, talk about 4 different common clinical entities that I commonly encounter on a weekly basis in a busy general surgery practice. And so let's get started. How common is abdominal pain encountered in a clinical practice? Well, just about everyone experiences abdominal pain at some point during the course of their lifetime. And when someone presents to the emergency department with abdominal pain, how common do the emergency room doctors encounter patients with abdominal pain? And typically, if you break down all the visits to the emergency room, about 5 to 10% of those visits are folks that are complaining about abdominal pain. Now, when patients present to their primary care doctor, about almost 3% of the primary care encounters involve abdominal pain. So it's important that you ascertain as a clinical provider what is the underlying cause of the abdominal pain. And so some of the common causes that primary care doctors encounter in the course of their practice are maybe not necessarily life-threatening problems necessarily. About 33%, or almost a third of the patients, they can't ever identify the underlying cause. About 17 to 18% can be gastroenteritis or a viral gastrointestinal infection. Irritable bowel is quite common. It's seen up to 13%. Urologic causes such as urinary bladder infections or kidney stones are seen about 5% of the time. Irritation of the stomach. People eat certain food items or alcohol or excess acid production can cause irritation of the stomach lining in about 5% of the patients that they see. Now, acute disease that needs immediate therapy and particularly involves me as a surgeon, such entities as appendicitis, diverticulitis, gallbladder, and possibly neoplastic or cancer type etiologies constitute a smaller percentage but are very important. Now, when it comes to abdominal pain, it can be broken down into acute pain or chronic pain. Now, acute pain can develop rapidly over the course of hours to a day or two and can come and go. It can come on rapidly, and it can relent, or it can come and progress and become worse and more pronounced. Now, it's important as a clinician to understand, too, in the elderly population or folks who are immunocompromised, whether they've been on chemotherapy or whether they've been taking steroids for whatever reason, they may have a blunted response to the underlying cause that's precipitating their abdominal pain. Now, chronic abdominal pain is described as pain typically that lasts for more than 3 months. It can persist for weeks, months, or years. And basically, it can come and go, or it can be persistent as well. Now, there are various types of abdominal pain. 3 primary types of abdominal pain I'd like to discuss are visceral pain, somatic pain, and referred pain. Now, visceral pain originates within the organs of the abdominal cavity, and it doesn't propagate from cutting, inflammation, or inciting events such as that, but simply there are stretch receptors. So as a hollow organ becomes stretched and more distended, then it precipitates a stimulus, and the visceral pain sensory fibers actually enter the spinal cord on both sides. So it's more of a vague, nondescript type pain. Somatic pain, however, originates the membranes that line the abdominal cavity, the peritoneum. The pain sensory fibers originate from the peritoneal membrane. And this does send signals from cutting, irritation, and inflammation. The sensory fibers enter one side of the spinal cord, and allows you to precisely pinpoint where the pain is. And I'll use the appendicitis as an example. In the early appendicitis, as the appendix becomes more and more and more distended and more inflamed, typically you have a vague abdominal pain, which is situated around the umbilicus. And as the process progresses and the inflammation becomes more pronounced, then the peritoneum, or the lining surface of the appendix and the abdominal cavity, becomes irritated, and then you can notice a migration of the pain from around the umbilicus into the right lower quadrant, precisely where the appendix is. So that explains that. So now referred pain deals with pain that is experienced by the patient in a physically disparate spot. For example, someone who has gallbladder disease and experiences pain in their shoulder or between their shoulder blades. This is pain that is experienced somewhere where there's not a disease process at hand, but in fact the pain is precipitated and radiates from a distant spot. And the sensory fibers overlap with fibers from other locations. Now, in terms of abdominal pain, there are things that can cause abdominal pain and processes and disease conditions that are not necessarily situated within the abdomen. And it's important that we're cognizant of this. Diabetic ketoacidosis, folks who experience sickle cell disease, sickle cell crisis, can experience abdominal pain. This is a systemic process and manifests as abdominal pain. Systemic lupus, porphyria, uremia, we see this frequently in folks who have renal failure. Elevated thyroid levels can cause this, and folks with renal failure that have hypercalcemia or patients with hyperparathyroidism frequently will complain of abdominal discomfort. Some of the toxic causes, such as heavy metal toxicity, mercury poisoning, some less commonly encountered things such as scorpion stings, which can cause pancreatitis, methanol poisoning. Methanol is a distillate byproduct that people who make their own alcoholic beverage may have methanol contamination of the substance. Black widow spider bites can also cause toxic precipitation of abdominal pain. Other thoracic causes, such as heart-related issues, unstable angina, myocardial infarction, pneumonia can cause abdominal pain, and pulmonary emboli, blood clots to the lungs. Some genitourinary causes, testicular torsion, also kidney stones can cause abdominal pain. Some infectious sources, strep pharyngitis, Rocky Mountain spotted fever, and mononucleosis can also cause abdominal pain. Some abdominal wall sources, muscle spasms, shingles, herpes zoster, and muscular hematomas can cause abdominal pain. Now, it's important to know when to seek medical care. When is abdominal pain an emergency? Some of the things that would cause, we would encourage you to seek medical care or evaluation. If you have abdominal pain anytime during the course of your pregnancy that's severe. Severe pain that is associated with tenderness to the touch of the abdominal wall, inability to control your bowel movements or even have a bowel movement. Chest pain, severe abdominal pain accompanied by bloody diarrhea or vomiting blood. Severe abdominal pain after you recently experienced an injury to the abdomen could indicate that there's a severe problem. Hard, rigid abdomen if you have difficulty breathing or dizziness and fainting, or any type of visual disturbances. Now, symptoms that are associated with mild to moderate abdominal pain that may not be emergent but may need a medical evaluation would be a mild to moderate abdominal pain that doesn't improve over 1 to 2 days or gets slightly worse. If you have mild to moderate abdominal pain and urinary burning, pain when you eat, and have nausea associated with the eating, rectal bleeding in the stool when you have a mild abdominal pain. If you have fever for over 100 degrees Fahrenheit for 3 or more days, or if you notice blood in your urine or a loss of appetite. These are all indications that there may be a more serious underlying cause. If you've experienced diarrhea for more than 5 days, or if you have vaginal bleeding associated with your abdominal pain and the vaginal bleeding lasts longer than usual. Also, if you experience abdominal pain while you know that you're immunocompromised, whether it be from taking steroids or whether you're on a chemotherapy regimen, we take this very seriously and you should seek medical attention. In terms of evaluating abdominal pain, what should a patient expect to experience when they present to their emergency department or to their primary care provider to be evaluated for abdominal pain? Now, it's important to know that a primary care provider or emergency room physician sort through this very rapidly and ascertain whether the process is a mild self-limiting process or could it potentially represent a severe life-threatening process. So you can break it down into the acute. Has this been going on fairly onset very recently, or is this more of a chronic nature? The provider is going to ask you a very detailed question about how long have you been hurting? What are some of the aggravating or relieving factors? Does the pain get worse or better when you eat? Where's the pain located? Because the underlying process can frequently be determined or there's an indication of what may be causing the pain as to where the pain is situated in the abdominal cavity. Are there any other associated symptoms that you're experiencing with your abdominal pain? Are you having nausea and vomiting? Are you having fever? Are you having passing blood? Are you vomiting blood? These are all very important. The color of the stools will be asked. Any coexisting medical conditions may have a bearing on why you may be having abdominal pain, or any medications you may be taking are important. So these will all be asked. Has there been travel abroad? Have you been out of the country? Have you eaten unusual foods? Have you been around anyone else who's been sick? Have you been around anyone else with similar symptoms? And also a very detailed medical and surgical history will be obtained. The age and sex of the patient is important. Certain entities affect patients when they're younger than, say, when they're older, or certain entities affect men but not women, and vice versa. So those are important considerations. Physical examination will be performed, pressing on the abdomen, a full head to toe physical examination, and ascertaining whether or not peritonitis is present. And a physical examination is very important in terms of determining how severe the clinical entity may be. Also, in examining the patient, we can ascertain frequently whether a hernia is present and whether this may be implicated, or perhaps an enlarged spleen, or even perhaps a palpable abdominal mass. And of course, basic labs will be obtained, and this helps us sort through the differential diagnosis of what could be the underlying cause. And then, of course, as warranted, various imaging modalities could be used: ultrasound, CT scan, MRI, and others. Now, as I said before, the location of the abdominal pain is important to help us sort through what the patient may be experiencing and why they may be having the problem. This chart here is helpful, and if you look, for example, in the right upper quadrant, in the upper quadrant, you can see that that's where the gallbladder and the stomach are situated, and so problems with those organs would be implicated if someone came in with pain in those areas. Less likely to be those clinical entities, for example, if they came in with left lower quadrant abdominal pain, which, as you can see, the colon is situated down there, and very frequently diverticular disease of the colon presents as left lower quadrant abdominal pain. So that's very helpful to know where the complaints are arising from as to what may be causing the underlying issue. So in a busy general surgery practice, we see a number of different things, but these four entities are seen almost on a weekly basis. And so 4 clinical entities I'd like to discuss are gallbladder disease, what we call cholecystitis, acute appendicitis, diverticulitis, and also briefly discuss abdominal wall hernias. Cholecystitis can either be acute or chronic. It can be with or without gallstones. So when the ultrasound is performed, there may or may not be gallstones. If an ultrasound is performed and gallstones are not present, then a hepatobiliary scan, which is a functional test, helps us ascertain whether the gallbladder could be implicated. Typically, patients come in with pain in the right upper quadrant of the abdominal cavity, and a lot of times it happens after they eat, sometimes immediately, or sometimes it can be an hour or two later. Sometimes they don't have pain at all, they just have nausea. They learn that when they eat, they feel bad, and so then they develop an aversion to eating. And frequently, patients will come in and they will have lost 10, 20 pounds sometimes over the course of several months. And so it's important to sort this out. Also may experience some gas, bloating, loose stools, and these are all directly reflective of malabsorption of fat. And some of the things, like I said, in working up a gallbladder we typically will start with an ultrasound, and if that's negative, move on to a hepatobiliary scan, and that simply shows us how well the gallbladder functions. And sometimes problems with the gallbladder are seen initially on a CT scan of the abdomen, which may be performed for other reasons. Also, we'll order a CBC and a complete metabolic panel to ascertain how the liver function tests look and if the liver is being adversely affected or the biliary system. Treatment for gallbladder disease is removal of the gallbladder, and this can be done a variety of ways. Laparoscopically is most common, robotically is also common, and sometimes open cholecystectomy is reserved for the more complicated patients if needed. Also, IV fluids are administered, and of course antibiotics. Acute appendicitis. Acute appendicitis is essentially inflammation of the appendix. Appendix arises from the first portion of the colon called the cecum. We most commonly see it in the earlier stages of life, typically between ages 10 and 30, but it can be seen in the elderly as well. Mortality for acute appendicitis is low, fortunately, with it being as common as it is. Varying between 0.1% and 2 to 6% if the appendix is perforated. And it can be as high as 9% in the elderly, frequently due to coexisting comorbidities. A fecal lith is a hard piece of stool that becomes inspissated or impacted into the opening of the appendix, and the lining of the appendix continues to proliferate mucus, and the stool basically stops up the appendix, and that's what leads to the distension and sometimes perforation of the appendix. And appendicitis can occur with or without a fecal lith. Symptoms we normally hear are the pain that begins around the umbilicus or the belly button and then ultimately migrates to the right lower quadrant, but it can be quite variable. Frequently, the appendicitis is associated with nausea and vomiting or a lack of appetite. Patients just don't feel like eating, they just don't feel well. And frequently we see fever as well. Commonly, we'll order a CT of the abdomen and pelvis in adults. Now in children and children's hospitals, ultrasound is typically the favored modality to evaluate for ultrasound. They're very commonly used and are quite helpful also in avoiding radiation exposure for the children. CBC is ordered to help look at the signs for infection, and of course the physical exam that we've discussed. Treatment for appendicitis is removal of the appendix. Laparoscopic or open is typically the various approaches, and of course IV fluids are administered and antibiotics are given as well. Diverticulitis. Now, the diverticulitis is inflammation of a colonic diverticulum. Diverticulosis is simply the existence of outpocketings from the colonic wall. When those outpocketings become impacted with stool or become inflamed, then this can lead to diverticulitis. And so that's what we're discussing here. And what happens is the mucosa, or the lining of the colon, protrudes or pouts through intrinsic areas of weakness along the wall of the colon, and within that, stool becomes impacted, and that leads to infection, inflammation, and so forth. We most commonly see abdominal pain related to diverticulitis situated in the left lower quadrant, more so than on the right. Symptoms. Sometimes patients will report pain when they have bowel movements, sometimes nausea, sometimes vomiting and constipation, sometimes obstruction. Sometimes they pass blood in their stool. And so these are all things that we look for. Some of the diagnostics that we use for diverticulitis, CT of the abdomen and pelvis is incredibly helpful. We can see inflammatory changes in the area that's being affected. We can see other entities like abscesses that may be related, or perforation if a hole develops in the colon. And we can see these on the CT scan frequently. CBC, looking for infection, and of course physical examination and a clinical judgment based on the overall picture. Treatment for uncomplicated diverticulitis is frequently IV antibiotics. Some of the complications related to diverticulitis that we've mentioned: perforation, abscess formation, bleeding. Abscess can erode into surrounding structures such as the bladder commonly, can erode through the abdominal wall and cause a colocutaneous fistula, can erode into the uterus or other surrounding structures, or the small bowel. Patients can experience recurrent attacks. So if they've had an uncomplicated course, they've been on antibiotics for a period of time and went home, and then they wind up back in the hospital, and this is a repetitive, recurrent problem, then these are folks that we look at to talk to about surgery. Hernias. Basically, a hernia is a defect in the abdominal wall where you have protrusion of the intra-abdominal components through this defect in the abdominal wall. Now, if these abdominal contents become trapped and cannot go back in or re-enter the abdominal cavity, this is what we call incarcerated. And when the incarcerated contents lose their blood supply, we refer to this as strangulation. And this is, of course, a surgical emergency. Some of the symptoms that patients experience with hernias: you can have pain, you can have bowel obstruction, and strangulated bowel can lead to sepsis, of course, and death. Hernias are typically evident. Most folks, you can palpate an abdominal defect and a bulge perhaps, sometimes on larger patients, and depending on the fat content, it's harder to appreciate hernias clinically. And frequently we'll order a CT of the abdomen and pelvis to better elucidate any or show any hernias if they may be present, hopefully. Inguinal hernias are the most common hernias we see. Most common, they're 75% of the hernias, more common in men than women. Some of the risk factors for inguinal hernias are obesity, heavy lifting. If your job requires you to lift a tremendous amount of weight, it's not uncommon to see folks coming in with hernias. Patients who have chronic increase in intra-abdominal pressure, like chronic cough, like patients that have COPD, patients who strain frequently with having to urinate and so forth due to benign prostatic hypertrophy or difficulty urinating. Patients who may have a chronic cough, like related to medications they may be taking. Chronic constipation. Also, pregnancy can lead to inguinal hernias and frequently umbilical hernias. Patients who have liver failure and fluid in the abdominal cavity, or renal failure patients where peritoneal dialysis is performed, can frequently develop inguinal hernias. Femoral hernias are much less common. We see they represent about 5% of hernias, more commonly seen in women than men, about 10 to 1. And these are frequently seen in elderly females, but not exclusively. Abdominal hernias are more common in women than men, typically presenting with a bulge and discomfort at the umbilicus, or the belly button. Also, types of hernias, ventral hernias in the abdominal wall. Sometimes folks have had previous surgery, and where the scar is present can separate and lead to what we call an incisional hernia, and protrusion of the abdominal contents through the defect in the muscular abdominal wall. Treatment for hernias is surgical repair. Open, laparoscopic, and robotic techniques are available. Basically, the approach will depend on the size of the hernia, the location, and patient-related factors. All right, we've had a few questions here. The first question is, what causes appendicitis? Appendicitis is most commonly caused by an occlusion of the opening of the appendix, the lumen, if you will, becomes occluded by a piece of stool, and the lining of the appendix continues to produce mucus, and the pressure builds up, and the inflammation begins, and as the pressure builds up, this surpasses the blood flowing into the appendix, and the appendix can ultimately lose its blood supply and then ultimately perforate. Other causes of appendicitis are infections. Tumors can cause appendicitis, and other medical entities. Another question, what can happen if a hernia is not treated? Well, if a hernia is not treated, if the hernia is asymptomatic, depending on the size and the location of the hernia, if a hernia is symptomatic, it can very easily increase in size. The symptoms, the discomfort and the abdominal pain, frequently are signs that inflammation or irritation is occurring. Now, patients, as we've said before, may experience nausea and vomiting and bowel obstruction type symptoms. Frequently untreated, the hernia can increase in size. Now, what we are most concerned with is the abdominal contents that have herniated through the abdominal wall, losing their blood supply and moving from what we would consider a incarcerated hernia that cannot be reduced to a strangulated hernia that has lost its blood supply. And that, of course, is a surgical emergency. Another question is, when can I go back to work after surgery? Now, that commonly depends on the type of surgery that we're discussing, but most major abdominal surgery, we typically will use 6 weeks as a guideline, major abdominal surgery. And within the course of 6 weeks, typically people have realized about 90% of the tensile strength that they will ultimately develop in their healing process over the course of 6 weeks. So that really is a true hard, fast number. 6 weeks is the guideline we typically will use. And I'd like to thank you for the opportunity today to talk to you about abdominal pain, and I appreciate your time.
We hope you enjoyed the presentation today. If you would like to schedule an appointment with Dr. Young, talk with your primary care provider about a referral. If you do not have a primary care provider, please call 903-596-DOCS, DOCS, or visit uthealthiestexasdoctors.com.